Catrice described an overview of generally how policies will affect us in the workplace. Aiden is now going to do a deeper dive and present a specific policy you might encounter during your work.
Hi, my name is Aidan Lisney, and today I'm going to be talking to you about policy and policy change in the context of substance abuse. For most of our presentation, we've spoken to you about policy from a broader perspective. For my portion of the presentation, I want to zoom in on one issue that's affecting our nursing care and healthcare at large, and show how that affects policy, our attitudes, and our actions. I was inspired by a statement issued by the Joint Commission that said, when viewed and treated as a chronic medical illness, treatment outcomes for substance abuse disorders are comparable to those of other diseases, such as asthma, diabetes, and hypertension, and can result in lasting benefits. This is exciting to me because it illustrates the trajectory of substance abuse policy in healthcare, even though we have a long way to go. I would also like to add a disclaimer that some of the views that I will be talking about in here don't necessarily reflect my own views on policy change. I'm just presenting the issues as they are. I have two objectives for my portion of the presentation. One is an overarching objective, and that's simply to inspire you to get involved with policymaking, whether it's on a national level or whether it's on an institutional level, which might be a little bit more realistic. My second objective is for you to be able to describe the difference between disciplinary policy and alternative to discipline policy, which I'll speak of later. My goal is not to educate you on addiction per se, but rather to discuss policy that formed around substance abuse in healthcare. Even as such, I'm going to give you a definition of addiction. The American Society of Addiction Medicine has defined addiction as a primary chronic disease of brain reward, motivation, memory, and related circuitry that leads to characteristic biological, psychological, social, and spiritual manifestations. Who is affected by addiction? The short answer is that everybody is affected by addiction. 21% of Americans have at least one addiction, and 10% of them actually receive treatment for it. 30 Americans die every day in alcohol-related car accidents. 130 Americans die every day from an opioid overdose. And 20 to 30% of people who take prescription opioids misuse them. These are pretty random statistics, but I'm just showing them to illustrate how far-reaching and how destructive substance abuse is. Our nation started to outlaw drugs sometime in the 1870s with anti-opium laws. That progressed to the 1900s where anti-cocaine laws were introduced, and the 1910s and 20s where anti-marijuana laws were introduced. In 1971, President Nixon declared the war on drugs, and in the 1980s, Nancy Reagan heralded the campaign Just Say No, and DARE came along. There were all these different programs which promoted a zero-tolerance look at drugs and incarcerated people instead of helping them. This negative attitude spilled out into healthcare, and as a result, we battle with these negative attitudes today. Studies show that doctors and nurses have negative attitudes towards people that are addicted to drugs and people they perceive are seeking drugs. However, the tide is starting to change, and it's starting to match how we're viewing other chronic long-term illnesses. This change is moving from punitive to therapeutic. It's becoming more based on compassion and evidence. We're now starting to treat addiction as a disease and not like a moral issue. You can see this in how we are now using medication-assisted treatments like Suboxone and Narcan. How does this sound to you? Does punishment or compassion sound closer to the methodology that we learn in nursing school? Do we extend the same courtesy and offer the same compassion that we do to the overweight patient with type 2 diabetes as the patient we have that is addicted to crack cocaine? We are now seeing the advent of harm reduction services and policy, which aim at keeping those that are addicted to drugs and alcohol safe rather than inflicting some kind of punitive measure upon them for their addictions. This policy offers a variety of different services. One of these services is offering clean needles to those that are addicted to IV drugs. Another service is administering drug testing kits so that those that are going to be taking street drugs know that the drug that they purchased is the drug that they're intending on taking. Providers are now educating patients on basic phlebotomy, sexual health, and wound care. There's also better access to Narcan and other medication-assisted treatments such as Suboxone, arguably the best aspect of harm reduction policy. There are now sites called supervised injection sites, which are pretty controversial. These locations allow the IV drug user to go under the direct supervision of a healthcare provider, who administers the drug for them and is able to continually assess them so that they're kept safe while under the influence. We now have Good Samaritan laws being put into place that incentivize people to take their companions to the emergency department if they're overdosing without the fear of retribution or getting in trouble by the law. How do these services benefit us? Well, a third of IV drug users aged 18 to 30 have hepatitis C. There are many ways that we could view this, but I'll present two. We could view it from a compassionate perspective, where we're seeing a large population of people that are vulnerable and contracting a terrible disease and desire their recovery for them. The other way we can view this is from a safety perspective. We're coming into contact with these patients that have hepatitis C and have contracted it through means that are modifiable. If we can educate this population or provide them access to clean needles, we might be able to reduce the amount of people that are contracting these diseases and in the end prevent certain healthcare providers from contracting those diseases as well. It's shown that these harm reduction services reduce the amount of drug-related deaths. I think as healthcare providers with patient-centered care as our prerogative, this fact should really speak to us. These services also help develop a trust between healthcare providers and addicts, and it opens a doorway of communication between us. Historically, we know that communication hasn't been very good, but by developing these judgment-free attitudes and actions, we might one day open the door for somebody to come to us with their own problems, somebody that we didn't even know was struggling, such as a coworker or a family member or a friend. Perhaps we could help facilitate the recovery by this mentality adoption. Lastly, these services sharpen our skills as healthcare providers. As nurses, we embrace education wholeheartedly, and we should be jumping at the opportunity to have new education moments with our patients. This also gives us an opportunity to be a better advocate for our patients as we now have new services that we can discuss with them and provide for them. Let's talk about substance abuse in healthcare. It's estimated that 1 in 10 nurses abuse drugs or alcohol, and it could be anywhere of 14 to 20% of RNs have an actual developed addiction. 1 in 10 physicians will abuse drugs or alcohol at some point in their lives. What is the mechanism behind this? There's not one specific risk factor involved with addiction, but for healthcare providers, it seems to be related to the long shifts that they work, the stressful work environment they're in, and having access to drugs like fentanyl and morphine. It's also easy to divert these medications. There's a lot of waste with opioids, and it's easy to take that waste without anyone noticing. Healthcare providers also have an advanced knowledge of these medications and know how to abuse them. But how does this affect us as nurses if we ourselves don't directly battle with an addiction? Why should we care? Well, this answer really comes back to us at some point in our careers. These are our patients. These are our coworkers. They're our family, and they're our friends. And we don't know, one day this could be you, it could be me. It would benefit us to be concerned about substance abuse in healthcare because this illness is shaping our policy and it's forming our work environment, whether perceptibly or imperceptibly. Let's talk about disciplinary policy versus alternative to discipline policy. Many healthcare institutions have in place punitive or disciplinary actions that they take against healthcare providers that are caught under the influence of drugs and alcohol or diverting medications on the floor. Some of these are zero tolerance policies, where the first time that this would happen, the provider would be immediately terminated. For a nurse caught under the influence, due process could be taken against them involving the State Board of Nursing. Their license would then be suspended or it could be revoked. They would then be fired from the institution and would no longer have health insurance. The consequences would be even more severe if they were caught diverting medications. Legal action could be taken against them. They could be incarcerated and then incur a criminal record, and this would effectively destroy their career in healthcare. What I really like about the Joint Commission statement that I read earlier was that it pointed out the illogic of these punitive and disciplinary policies. If we as nurses provide compassionate, evidence-based care for our patients, why are we not having the same thing given back to us? From that type of mentality evolved alternative to discipline policy, which aren't, despite the way the names sound, lax in their treatment of the provider who's caught under the influence. However, these treatments are evidence-based and they are compassionate at their core. Under an alternative to discipline policy, if a healthcare provider, such as a nurse, was reported to be under the influence on the floor, their supervisor would have an intervention for them, in which they would present the alternative to disciplinary policy to them and offer them the ability to attend a rehabilitation program. This would be done in conjunction with the State Board of Nursing as well, and through a third party like PNAP, which is an excellent program that nurses can go to that struggle with substance abuse disorder. Throughout this process, there would be periodic drug screenings, probably an initial psych evaluation, and mandated program attendance to Narcotics Anonymous or Alcoholics Anonymous. They would then have a return to work agreement in place where the nurse would only have a limited amount of hours that they could work. They wouldn't have access to narcotics, and they wouldn't be able to work on certain shifts like night shift, where it might be easier to obtain those drugs. This continual monitoring and assessment process would last for 3 to 5 years. Now, these policies aren't done everywhere, and it varies from state to state. However, they do allow nurses to get help by keeping their insurance plan, and they promote recovery. In the end, policy is important because it's a reflection of us as nurses on a macroscopic level. These are the thoughts, attitudes, and actions that are directly linked to our nursing care. So, does the idea of changing policy bother you in regards to substance abuse? How do you personally feel about clean needle administration or safe injection sites? Perhaps you like aspects of these changes, like incorporating evidence-based practice and compassion into your care, but you think that some aspects are immoral. How do you feel about alternative to discipline policy? If these changes evoke a negative feeling inside of you, I think that that's good. I think that this is something that can move you towards action. If you feel positively about these changes, I think that's great too. Your feelings toward these changes should push you towards being a part of the solution. There are many ways that we can do this in regards to substance abuse. There's the Pennsylvania Nurse Peer Assistance Program, which I spoke to you about earlier. It's a monitoring and advocacy program that's approved by the Pennsylvania State Board of Nursing. They're dedicated to helping us nurses and nursing students deal with substance abuse disorders, mental health disorders, and any disorder that might affect our ability to practice. If you wanted to become involved with change on the national level, you could join the National Council of State Boards of Nursing, which is an organization dedicated to providing safe nursing care for the public, and they're also dedicated to advancing the profession of nursing in general. However, these are just two options that we have as nurses to take to improve policy and to participate in policy change. Ultimately, I hope to see us get interested and involved in small ways so that way we can take more responsibility in the care that we're providing for our patients and we can feel a little bit happier about the environment that we work in. Thank you.
Hi, this is San. Now that we have talked about what policies are, how they are developed, and how they can impact us as nurses, I am going to talk about policy changes and the role of leadership and advocacy. Healthcare reform is always a hot topic, especially during election time. But healthcare is a constantly changing arena. There are a couple of factors for this, mainly due to costs, but also because there is an abundance of needs and there are identified gaps in care. Being able to identify these gaps and bring them to the forefront supports the spirit of inquiry, which is an NLN competency. Policies have to change with the times. To keep up, modifications to existing policies need to occur, or development of new policies is crucial. Changing with the times is something I call landscape changes. An example of a landscape change is a policy Catrice mentioned earlier, HIPAA. Prior to HIPAA, there was a lot of information sharing and policies were not strong enough to adequately maintain patients' rights to privacy and confidentiality. For example, prior to HIPAA, everyone knew that Aerosmith was at the Cairn Foundation. They knew when they got there, what they were doing there, and how long they were there. After HIPAA was developed, every agency needed to strengthen any existing policy they had or develop new ones to address patient privacy and confidentiality. Another reason policies have to change is with technological advancements. An example of this is electronic health records or electronic medical records. Once upon a time, it was all paper charting. Once the technology was developed for an electronic health record, all agencies needed to develop new policies to address this new technological advancement. Change is necessary, but adapting to change makes or breaks you. To help you navigate these changes, you need a strong leadership team. Leadership is a process by which a set of skills and attributes are used to affect change at all levels to attain a common goal that advances healthcare. Leadership influence is important in advancing health reform. This semester, we learned about formal leaders, like members of your management team, who will develop and implement any new policies that address changes in federal or state regulations. But we also have informal leaders, such as your direct care staff, who will also help in policy change by getting buy-in from others. Developing leadership competencies in your direct care nurses will result in advancing priority advocacy needs at all levels, attaining equitable healthcare services, and improving population health. Leadership skills do not come naturally for many. They need to be developed. We know the importance of evidence-based models as they are research-based and have proven positive outcomes. One evidence-based leadership development model is the Kouzes and Posner model, which has 5 main components. Modeling the way is very similar to this quote by Mahatma Gandhi, "Be the change you want to see in the world." It's not about talking the talk, it's about walking the walk. So for example, if you say that nursing is a caring and compassionate field, then you will treat your clients, patients, staff, and students with the same care and compassion. Inspiring a shared vision. Many of us have differing views and opinions, but when we work for an organization, it's important to have a common goal, a shared vision. Many agencies have a mission statement which serves as their shared vision. Challenging the process. Quality of improvement is continuous and constantly assessing and evaluating our processes to determine if they result in the best care for our clients is important. Cultivating this type of questioning or spirit of inquiry in our leadership is also important. Encouraging the heart. Many people going into nursing are passionate about caring for others. Leaders encourage this passion and allow passion to be the voice. Enabling others to act. Some leaders want people to just fall in line and do as they are told. Good leaders validate people's contributions, support their voice, and encourage them to get involved. As I said, leadership skills need to be developed, and using an evidence program is critical in establishing a strong foundation of advocacy skills in direct care nurses. So what is advocacy? There are many definitions of advocacy out there, but the one I like states nurses' actions of arguing positively on behalf of patients, families, or populations to persuade others of needed change that contribute to health and healthcare improvements. This requires some nursing judgment, which is an NLN competency. When I say it requires some nursing judgment, I mean that you have to be able to identify the issue, support your issue with data and evidence, know the right person to bring your issue to, and also know the right time to do that. This requires some nursing judgment. Advocacy in policy and politics is the mechanism by which change occurs in healthcare systems at both the micro and macro levels. And advocacy is not only about advocating for patient care, but it's also about advocating for yourself and your peers in things like staffing ratios, and also the nursing profession as a whole. It lends itself to the spirit of human flourishing, which is an NLN competency. Why should nurses be on the forefront of healthcare reform and advocacy? Well, nurses are natural advocates. Advocacy and policy are not new to the nursing profession. From Florence Nightingale's formative Notes on Nursing, What It Is and What It Is Not, to the Institute of Medicine's 2011 report, The Future of Nursing, Leading Change, Advancing Health. Both of these reports focus on nurses as a critical player in advancing healthcare as they are on the front lines and have knowledge of what works and what doesn't. They can identify care gaps and can improve the workforce data collection and analysis process, which can lead to improving policies and procedures. Also, nurses are sometimes frustrated by regulations or policies directing nursing practice, especially when they're generated by those with little knowledge of healthcare. Many of the policymakers on Capitol Hill have little or no healthcare experience, which can be frustrating. So a number of nurses have used this frustration to fuel productive changes and become nurse advocates. They've taken on this new role to influence and change the policies, laws, and regulations that dictate our practice and how the larger healthcare system works. So now that you're super excited about advocacy work, where do you begin? Here are a couple steps. First, find an advocacy mentor. There are people who do advocacy work on a full-time basis and would love to share their passion and skills with you. 2, enhance your advocacy skills. Keeping up to date with changes in the world and within our field is important. Many times when you're watching the news, you might think that what's happening does not have anything to do with you, but many times it will affect healthcare policies in some way or another. Read journal articles and be aware of the latest research. Staying up to date on evidence-based practices in your field will be very helpful. 3, joining professional nursing organizations which can enhance development of your professional identity, which is an NLN competency. Many agencies have a healthcare policy and advocacy committee that you can join. And some of you have already started in advocacy by being part of our Student Nursing Association. You just heard me talk about how policy changes are necessary and important, but all essential workers will appreciate this slide as many policy changes came fast and furious in the last, it's been 6 weeks now, and our hair looks like it's on fire. Now that you know some information on this topic of nursing professional policy, tell us what you think. How do you feel about nurses who have a history of substance use issues being allowed to work with medications in general? How do you envision yourself being an advocate in the nursing profession? What types of activities would you be involved in? And do you envision the current coronavirus pandemic affecting change in current policies? If so, how? I know one group is doing telehealth, and so maybe think about changes in that area. All of our presentations focused on the importance of the nurse's role in advancing healthcare policies, policy development, and changing policies. I want to leave you with a quote by Loretta Ford. Loretta Ford is an internationally renowned nurse educator. In the 1960s, she identified a gap in care related to the shortage of primary care physicians. She was at the forefront of the nurse practitioner movement to train nurses to be advanced practitioners to help bridge that gap in care. She says, "Get to the table and be a player, or someone who does not understand nursing will do that for you." I hope our presentation motivated you to take some action as we are the change makers of the future. Quarantine, Class of 2020. Thank you.